Hello everyone, I welcome you back to the series of lectures in cardiology. Today we will be discussing about a very important topic, which is heart failure. Okay, so let us look at the definition of heart failure. Heart failure is defined as a complex clinical syndrome which is characterized by elevated cardiac filling pressures or inadequate peripheral oxygen delivery at rest or in stress. At rest or in stress. So, this is a complex clinical syndrome characterized by what? Characterized by elevated cardiac filling pressures. Why has this term been introduced in the definition of cardiac failure? Is because of this entity which was recently discovered, which is your heart failure preserved ejection fraction. So, this heart failure preserved ejection fraction is characterized by elevated cardiac filling pressures, and that is the reason why this has been included. Or there is an inadequate peripheral oxygen delivery, which means that there is a decreased cardiac output. So, heart failure can be characterized by decreased cardiac output or elevated cardiac filling pressures. Okay, so this is about the definition of heart failure. Now, let us look at the classification of heart failure. Let us look at the classification of heart failure. So, heart failure is classified as heart failure reduced ejection fraction, mid-range or mildly reduced ejection fraction, and preserved ejection fraction. So, what is reduced ejection fraction? When the EF is less than 40%. Okay, when the EF is between 40 to 50%, it is called as mildly reduced. And when the EF is more than 50%, this is called as heart failure preserved ejection fraction. Okay, so that is about your classification. Let us look at the etiology of heart failure. Heart failure reduced ejection fraction can be because of the most common cause, coronary artery disease, because of MI or myocardial ischemia can cause heart failure with reduced ejection fraction. Secondly, valvular heart disease. So, any aortic or mitral or tricuspid valve disease can cause heart failure reduced ejection fraction because over the course of time, it can cause dilatation, chronic volume overload or pressure overload, and the LV fails. Then congenital heart disease because of shunts or defects and right ventricular failure can cause heart failure. Infectious diseases, we know that Chagas and HIV is associated with what? It's associated with dilated cardiomyopathy, which can further cause heart failure. Non-ischemic causes, the most common cause is ischemic, then we have to look at non-ischemic causes like infiltrative familial disorders, tachycardia induced, which are all basically causes for cardiomyopathies. Okay, this is nothing but your cardiomyopathy. Then we have the toxic cardiomyopathies, which include chemotherapies and drugs such as hydroxychloroquine. Then we have autoimmune diseases like giant cell and lupus myocarditis. We have autoimmune diseases like giant cell and lupus myocarditis are the other causes for heart failure with reduced ejection fraction. So, heart failure with reduced ejection fraction can be classified due to coronary artery disease and non-ischemic causes. Under non-ischemic causes, the various causes for your cardiomyopathies are grouped under that. Heart failure with preserved ejection fraction. Coronary artery disease can also cause heart failure with preserved ejection fraction, but always remember HFpEF is a comorbidity driven disease. HFpEF is a comorbidity driven disease. So, hypertension. Remember, heart failure preserved ejection fraction is a comorbidity driven disease. So, hypertension, diabetes, OSA, all of these can contribute to HFpEF. Obesity can also contribute to HFpEF. Apart from this, we have valvular heart diseases where there is a pressure overload like AS and MS. Then we have restrictive cardiomyopathy. Remember, dilated cardiomyopathy, the EF will be low, but restrictive and hypertrophic cardiomyopathy is associated with a heart failure preserved ejection fraction. Constrictive pericarditis. Constrictive pericarditis again causes a form of right ventricular failure, so it is a cause of heart failure with preserved ejection fraction. Now, let us look at this component, which is the high output cardiac failure. So, high output cardiac failure is seen in thyrotoxicosis, obesity, anemia, cirrhosis, beriberi, and certain forms of myeloproliferative neoplasms. So, thyrotoxicosis, obesity, cirrhosis, beriberi, certain forms of myeloproliferative neoplasms, all of them are causes of high output cardiac failure. So, that is about the etiology of various types of heart failure. Now, let us look at the pathophysiology. The first pathophysiology is your heart failure with reduced ejection fraction. So, let us look at the neurohormonal mechanisms. So, what are the mechanisms responsible for the heart failure with reduced EF? So, the first step, so whenever there is a failing heart, there will be some kind of a compensatory mechanism which is stimulated. So, the first compensatory mechanism is that there is activation of the sympathetic nervous system. Why? Because the sympathetic nervous system recognizes that there is a decreased organ perfusion. So, there is natural activation of the sympathetic nervous system, and this sympathetic nervous system decreases the peripheral blood flow. It decreases the blood flow to the peripheries and starts to retain or increase the blood flow to the coronaries. So, that is the first thing. Second thing, as a compensatory mechanism, the increased sympathetic blood flow will stimulate, increased sympathetic activity will stimulate tachycardia. It stimulates tachycardia so that the cardiac output can be maintained by increasing the heart rate. Okay, so that is the first mechanism. The second mechanism, the failing heart also senses that there is the failing heart also means that there is a decreased perfusion to all the other organs. There is a decreased perfusion which causes a baroreceptor dysfunction. It causes a baroreceptor dysfunction. This baroreceptor then causes stimulation of two portions. One is the RAS system and the other is the vasopressin system. Okay, so one is the RAS system and the other is the stimulation of vasopressin. What is this RAS system? It stands for the renin angiotensin aldosterone system. So, what happens in this renin angiotensin aldosterone pathway? So, what happens in this pathway is that whenever there is a decreased perfusion pressure, the kidneys are stimulated. The kidneys feel that there is a decreased perfusion pressure and hence they should retain sodium and water. Because they feel that there is a volume depletion, there is decreased perfusion pressure and they retain sodium and water as a response to this decreased perfusion so that they maintain the volume status. Okay, because they consider that the decreased perfusion pressure is the diffuse perfusion pressure is mainly because of the decrease in volume, and to maintain the volume status they retain the sodium and water and they prevent excretion of sodium and water. And how is this brought about? This is brought about by stimulation of renin. So, whenever there is a decreased perfusion or decreased renal blood flow, there is stimulation of renin. So, renin causes stimulation of angiotensin. And the function of angiotensin is this: increase sodium and water resorption, and also causes incretion of another molecule which is aldosterone, which also helps in the retention of sodium and excretion of potassium. Fine. So, that is about your RAS system. And what is the function? What is the function of this vasopressin? Vasopressin is also called as the antidiuretic hormone. It causes antidiuresis. What happens when there is antidiuresis? Again, there is retention of water. Why? Because whenever there is a decreased perfusion pressure or a decreased blood flow, it is mostly due to hypovolemia. So, this is the compensatory mechanism that the kidney thinks. So, there is activation of the RAS system, there is activation of your antidiuretic hormone and sodium and water retention to maintain the volume status and to maintain the perfusion pressure. Alright, so this is about the basic neurohormonal mechanisms which are found in heart failure, reduced ejection fraction. So overall, whenever there is a low EF, what happens is that the perfusion pressure decreases. So whenever there is a perfusion pressure decrease, the blood flow to the peripheral organs decreases. The kidney compensates in these two manners. Okay. Now let us look at the remodeling stimuli. So what happens is that initially, in the initial time, there is wall stress and there is neurohormonal activation. So what happens? The myocyte becomes hypertrophied. There is alteration in the interstitial matrix. There is alteration in the interstitial matrix and there is ventricular enlargement. Apart from that, there can be alteration in the calcium binding proteins, and in the later stages, initially the heart is able to compensate. In the later stages, what happens is that there is decompensation. Because of this overactivation of the compensatory mechanisms, there is altered calcium handling and myocyte death, finally leading to systolic or diastolic dysfunction. Okay, so the initial stages all is good. The sodium water retention and the remodeling in the heart with the help of wall stress, the ventricle enlarges, everything is good and it is able to compensate for the failing heart. But over the course of time, these mechanisms become detrimental and there is myocyte death and systolic or diastolic dysfunction sets in. Okay, so this is about the pathophysiology of heart failure, reduced ejection fraction. Now, what happens when there are certain additional conditions in a patient with heart failure? What about electrical dyssynchrony? So, we know that the electrical activity of the heart is maintained by the SA node. So, the SA node causes activation of the AV node. Before it goes to the AV node, it causes activation of the atria. Then there is activation of the AV node, followed by which there is activation of the bundle of His, which causes activation of the left and right bundle branches, So, followed by the AV node, we have activation of the bundle of His, and we have the right and left bundle branches, followed by which we have the activation of the ventricles. Okay. So, whenever there is electrical dyssynchrony, which means that there is a block at the level of bundle of His or the right and left branches, which we call as the right bundle branch block or the left bundle branch block. So, whenever there is electrical dyssynchrony where one of the bundle branches are blocked, then what happens? The RV and the LV do not contract together. So, if the RV and the LV do not contract together, what happens to the EF? The EF will fall and the heart failure will in fact worsen. That is the reason why electrical dyssynchrony causes worsening of the heart failure. So, electrical dyssynchrony causes worsening of the heart failure. Okay. So, we have to avoid electrical dyssynchrony as much as possible, and what are the ways in which you can avoid this, we will discuss further. Now, secondary MR. Now, whenever there is heart failure, as the ventricle or the cavity dilates, what happens is that you can have dilatation of the annulus. So, you can have annular dilatation. Now, if there is annular dilatation, you can cause worsening of the mitral regurgitation. If the mitral regurgitation worsens, we know of a dictum that MR begets MR. So, MR begets MR and the heart failure worsens. Okay, the heart failure worsens. Fine? Okay. Now, let us look at the next type of heart failure, which is the heart failure preserved ejection fraction. So, the pathophysiology of heart failure preserved ejection fraction is slightly different from the pathophysiology of heart failure reduced ejection fraction. So, always remember this one line. Heart failure preserved ejection fraction is a comorbidity driven disease. So this is seen in patients with obesity, seen in patients with diabetes, hypertension, metabolic syndrome and OSA. Okay. So what happens in these conditions is that there is a LV diastolic dysfunction. There is an LV diastolic dysfunction. So whenever there is an LV diastolic dysfunction, we know that the LV EDP, which is the LV end diastolic pressure, increases. Right? So the LV EDP increases, which means that there is a backward pressure, there is an increase in the LA pressure, there is an increase in the pulmonary capillary wedge pressure, which causes lung congestion and pulmonary edema, and these patients finally present with dyspnea. Okay, so this is a comorbidity driven disease, and treatment of the underlying comorbidities forms the cornerstone of management of heart failure with preserved ejection fraction. Okay, so that's about the pathophysiology of heart failure reduced ejection fraction and heart failure preserved ejection fraction. Let us look at the precipitating factors of heart failure. If a patient presents to you with symptoms of heart failure, what do you think will be the precipitating factors? One is patient related. Always remember that many of the patients do not follow the advice that we give on discharge. So what is the advice that we should be given? We should be telling that they should follow a low salt diet and the restricted fluid intake to less than maybe 1 to 1.5 liters per day. So if these two are not followed, this can cause heart failure, because we have understood in the pathophysiological mechanisms that there is retention of sodium and water. So low salt diet and fluid intake is not restricted, then it can precipitate a heart failure. Apart from that, you also have to ask whether the patient is compliant to the drugs or not. Right? So these are the patient related factors that you should be looking at when a known case of heart failure presents with heart failure again. Okay. Then we have to look at the drugs. First thing is that we have to look at the treatment related issues. If the drugs are underdosed, so we have to look at the drug dosing as well. Second, there are certain drugs which can precipitate heart failure. So what are the drugs which can precipitate heart failure? We have NSAIDs, we have corticosteroids, and the anti-diabetic drug which can cause pedal edema and fluid and water retention is your thiazolidines, which is nothing but your drug like pioglitazone, right? So these are the drugs which can precipitate heart failure. So always remember, always ask in your history what all are the drugs that the patient is on, because suddenly for some other reason they have taken an NSAID or a steroid, they can have salt and water retention. Fine. Then we look at the medical causes which can precipitate heart failure. The medical causes which can precipitate heart failure includes anemia, because if they have had a GI bleed or bleeding from elsewhere, if the hemoglobin drops, then the oxygen carrying capacity of the blood drops, the heart has to function more. If the heart has to function more, the failing heart cannot cope up with it. So anemia can precipitate heart failure. If they have had a recurrent MI, so in a patient with coronary artery disease, if there is a second MI, or if they have had an arrhythmia, if they have had an AF, if they have had renal failure, we know that the kidney function is very essential for the excretion of sodium and water from the kidney. Now, if the kidney begins to fail, it will worsen the heart failure. Yes, it will cause more fluid retention and worsen the heart failure. This is what we call as the cardiorenal syndrome. Okay. So, cardiorenal syndromes are of 4 types. So, what are the 4 types of cardiorenal syndrome? So, we have the acute cardiorenal, where a cardiac disease is causing renal failure. Chronic cardiorenal, where a chronic heart failure causes renal failure. Then we have acute renocardiac, where acute renal failure causes cardiac failure, and a chronic renocardiac syndrome, where a chronic renal failure can cause cardiac failure. Okay. Also remember that many infections can also precipitate heart failure. So a diabetic presents with urinary tract infection causing sepsis, septic shock, he can also go into heart failure if he already has a weak heart. Okay. So this is about the various precipitating factors which you have to inquire in your history if the patient presents with heart failure. Fine. Now let us look at the clinical features of heart failure. What are the symptoms? Naturally, the patient can present with dyspnea because of pulmonary congestion. They can present with orthopnea. Orthopnea basically refers to the dyspnea which occurs on lying flat. So the dyspnea which occurs on lying flat is what we call as orthopnea. So why do you get orthopnea? It is mainly because of increased venous return on assuming a recumbent position. Because of increased venous return on assuming a recumbent position. So whenever there is an increased venous return to the heart, what happens? There will be immediate breathlessness, what we call as orthopnea, because the failing heart cannot manage that. Then we have the next symptom which is known as the paroxysmal nocturnal dyspnea, which is called as the paroxysmal nocturnal dyspnea. So in paroxysmal nocturnal dyspnea, what happens is that in a recumbent position, when the patient goes to sleep, after around 2 hours, there is development of which phase of the sleep cycle? There is development of the REM phase. So in this rapid eye movement or REM phase, what happens? There is increased sympathetic activity. There is increased sympathetic activity. Now, when there is increased sympathetic activity, what does that mean? There is an increased heart rate, but will the failing heart be able to cope up with this increased sympathetic activity? No. So, the failing heart cannot cope up with this increased sympathetic activity. So, it cannot cope up with this increased sympathetic activity. The failing heart cannot cope up with this increased sympathetic activity. So, it begins to fail further. So, the patient feels breathless and he feels that he has to go to the window and take some air. So, that is what we call as paroxysmal nocturnal dyspnea. Another novel sign which has been described in heart failure is bendopnea. Okay. Another novel sign which has been described in heart failure is bendopnea, which basically refers to the breathlessness which happens on bending down within 30 seconds. Okay. So, the breathlessness which happens on bending forward within 30 seconds is bendopnea. Okay. So, that is about the various signs which you see in the various symptoms which you see in heart failure. All of you must be aware of the NYHA grading of heart failure. So, what does NYHA stand for? It refers to the New York Heart Association functional classification of heart failure or heart failure symptoms. Okay. So, always remember the NYHA classification is used in a known case of cardiac disorder. In a patient with a known case of cardiac disorder, you use the NYHA classification. So, class 1 basically refers to the ordinary physical activity does not cause any undue fatigue, dyspnea, palpitations or angina. So, it includes all 4: fatigue, dyspnea, palpitations or angina. Okay. Class 2 basically means that the patient is comfortable at rest but ordinary physical activity can cause fatigue, dyspnea, palpitations or angina. Class 3 means that less than ordinary physical activity like getting dressed leads to symptoms. Class 4 means that the symptoms of heart failure are present at rest as well. So, where do you think orthopnea comes in? If the patient is already orthopnic, that means he is in class 4 NYHA, and if the patient is having PND, that means the patient is in class 3 NYHA. Okay, so that is about your NYHA classification. Now, let us look at the various signs that you can have in heart failure. Okay, let us look at the various signs which you can have in heart failure. On general physical examination, if the cardiac output is very low, what can you find? You can find cyanosis. Okay, you can find cyanosis. Can you find pedal edema? Yes, because of the failing heart, you can find pedal edema. Alright, the pulse, the very characteristic feature in the pulse is the presence of pulsus alternans. So, pulsus alternans basically refers to alternate of low volume and high volume pulse because of the difference in the cardiac output. Okay, this is definitely different from electrical alternance. So, electrical alternance is seen in as a ECG finding in cardiac tamponade. Okay, but pulsus alternans is seen in heart failure. Alright. So, what happens to the BP? The BP is usually low. When it comes to the JVP, we have something called as the hepatojugular reflex. So, how do you demonstrate the hepatojugular reflex? So, you place your hand over the liver, apply a firm pressure over the liver. So, normally when you apply pressure, there will be an elevation in the jugular venous pressure. The jugular venous pressure increases. This is normal, but it remains elevated. It remains elevated for more than 30 seconds. It does not fall. That means that this is a positive hepatojugular reflex because of venous congestion. Okay, so presence of a positive hepatojugular reflex is suggestive of impending heart failure. Fine. Now, what is the difference between a hepatojugular reflex and an abdominojugular reflex? So, how do you demonstrate an abdominojugular reflex? Is that you place your hand over the periumbilical area. You place your hand over the periumbilical area and you apply pressure. What happens to the JVP then? The JVP rapidly rises and falls. Okay, so the JVP rapidly rises and falls, and this is a sign of impending right heart failure. So, this is the difference between your hepatojugular reflex and your abdominojugular reflex. Alright, what happens to the apex beat? If the heart becomes dilated, the apex beat can be shifted laterally. What happens to the heart sounds? So, what happens is that whenever the heart fails and the chambers become dilated, the heart sounds also reduce in intensity. Right? So, they reduce in intensity. Okay. Will you have an S3 and S4? Yes, you have an S3 and S4 in the presence of heart failure. What are the different murmurs that you can find? The various type of murmurs that you can find is, you can have pansystolic murmur because of dilatation of the chambers. Because of dilatation of the chambers, you can have dilatation of the annulus and you can have a pansystolic murmur of MR. This type of mitral regurgitation is your secondary mitral regurgitation. Apart from that, you can also have ejection systolic murmurs and flow murmurs. You can also have ejection systolic murmurs and flow murmurs. What do you see in the lungs? Now, whenever there is pulmonary congestion, you can have presence of bilateral pleural effusions. You can have presence of bilateral pleural effusions. Apart from bilateral pleural effusions, when you auscultate the effusion, what will you find? You will find bilaterally decreased breath sounds. And just above the level of effusion, you can hear some bronchial breathing as well. What added sounds can you find? The added sounds you can find are, crepitations. You can have crepitations because of fluid accumulation within the alveoli, and these are fine crepitations. These are fine crepitations. Okay. Where do you find coarse crepitations? Coarse crepitations are found in lung conditions like bronchiectasis. Okay. You can also have some amount of these which is called as cardiac asthma. Okay. This is called as cardiac asthma. Then per abdomen examination, you will find abdominal distension. You will find abdominal distension. Why is there abdominal distension? Abdominal distension because of ascites, and you can find hepatomegaly as well. What type of hepatomegaly? This is a congestive hepatomegaly. Okay. So that is about your various examination findings. Now we look at a very important criteria which was devised in the management of heart failure, which is your Framingham criteria for diagnosis. So this includes major as well as minor criteria. So the major criteria are what we have learned already: the PND or orthopnea, neck vein distension, the presence of rales, cardiomegaly, acute pulmonary edema, presence of S3 gallop, and presence of hepatojugular reflex. Okay. Minor criteria includes ankle edema, presence of nocturnal cough. So nocturnal cough, which can be considered as a great mimic to asthma as well. Dyspnea on exertion, hepatomegaly, pleural effusions, vital capacity decreased by 1/3 from maximum presence of tachycardia. So these are about the major and minor criteria of the Framingham's criteria. And if there is a weight loss of more than 4.5 kgs in 5 days in response to treatment, when you give diuretics, there is a weight loss, then this is also considered to be a minor criteria. Okay. Let us look at the investigations which are used in the management of heart failure. So ECG can show various features which depending upon the etiology. So the ECG of ischemic heart disease can show the presence of Q waves. It can show the presence of previous MI. Q waves are suggestive of an old MI. You can have poor R wave progression. ECG of DCM can also cause poor R wave progression, right? So this ECG can help you identify the etiology in certain way, and different types of etiologies can have different ECG findings. X-ray. Let us look at the X-ray. You can see that the cardiothoracic ratio is increased. The CT ratio is more than 0.5. So this is suggestive of cardiomegaly. This is suggestive of cardiomegaly. Apart from that, you can have cephalization of the veins. You can have cephalization of the veins. So usually the veins do not extend up to the epiphysis. So cephalization of the veins is seen. Then you have some lines which are called as curly lines, right? So you have some lines which are called as curly lines. Then we have something called as curly lines. So the horizontal lines which are found parallel and horizontal in the lower part of the lungs, these are called as your curly B lines. These are called as your curly B lines, and the lines which arise from the perihilar region, these are called as your curly A lines. So curly A lines are perihilar. Apart from this, you can find effusions. Effusions are seen as blunting of the cardiophrenic angle. Blunting of the cardiophrenic angle. Okay. So these are the major X-ray signs of heart failure. Now on the echo, of course you can see the EF, you can see presence of MR, you can see if there is any evidence of cardiomyopathies as well. And you can see even the valvular heart diseases. Right? Okay. There are some biomarkers which are used in the diagnosis of heart failure. So the most important biomarker which is used is your NT-proBNP. NT-proBNP is nothing but your NT-pro brain natriuretic peptide. So what is the advantage of this is that if it is more than 1000, then there is a definite diagnosis of heart failure. Okay. But more often this only helps because it has a negative predictive value. It has a negative predictive value, which means that if it is negative, then it means that definitely there is no heart failure. But if it is positive, it does not always mean that there is heart failure. Okay. So NT-proBNP can be falsely low in obesity, and it can be false positive in a lot of other conditions. So if NT-proBNP is positive, it doesn't mean that it's always a heart failure only. So it can be falsely positive in renal diseases, in liver diseases. It can be falsely positive even in pulmonary embolism and in sepsis. Okay. So this is the reason why NT-proBNP has a good negative predictive value, but though it is positive, it does not definitely mean that there is heart failure. The newer markers which are now being used but not in practical study, they are being developed is galactin-3 and soluble ST2. So these are novel biomarkers which are being used, which are being studied in heart failure. Okay. So what is the role of cardiac MRI? Like if you go back and see your sessions in your cardiomyopathies, you can find out that cardiac MRI is basically used to identify whether this is an ischemic or a non-ischemic etiology. So you see the pattern of late gadolinium enhancement, and to know whether this is an ischemic or a non-ischemic cause for heart failure. To understand more details of the cardiac MRI, do visit the chapter on cardiomyopathies. Alright, the invasive methods. The invasive method is used, which is angiogram. Angiogram can be used to find out the etiology. When you do an angiogram, you can see the level of block in the coronaries. At the same time, if the block is significant, you can put a percutaneous coronary stenting, and the cardiac function can be restored after the stenting in atherosclerosis. Okay. Apart from that, you can also do CAT studies. You can do CAT studies, but these are not performed any longer. Now let us look at the staging of heart failure. Staging of heart failure. Stage A means that they are at risk of heart failure. So the patients are at risk of heart failure. Those patients with a lot of comorbidities like cardiovascular disease, diabetes, obesity, exposure to cardiotoxic agents, cancer patients who have undergone chemotherapy, genetic or cardiomyopathies, familial history of cardiomyopathies. All these people are at stage A, where they have risk factors but they do not have the symptoms, or biomarkers have not yet developed and imaging does not show any evidence of heart failure. In stage B is known as pre-heart failure. So in this, the patients do not have any symptoms or previous symptoms, but they have evidence of what? They have evidence of structural heart disease or increased filling pressures. When you do an echo, you see evidence of a structural heart disease or increased filling pressures, and the risk factors in terms of proBNP levels are increased, or a troponin level is increased. So pre-heart failure, where they are not symptomatic but there are some structural changes and some biomarker changes are seen. Stage C is your symptomatic heart failure, and stage D is your advanced heart failure, who are in NYHA class 4. Stage D is your advanced heart failure, who is in NYHA class 4. Okay. So that is about the staging of heart failure. Fine. Let us move on to the management of heart failure. First, we will be looking at the management of HFrEF. Always remember that there are 4 pillars which are used in the management of heart failure with reduced ejection fraction. There are 4 pillars which are used in the management of heart failure with reduced ejection fraction. So, what are these 4 pillars? So, you have to remember that ACE inhibitors and ARNI, beta blockers, SGLT2 inhibitors and MRA. So, these are the 4 pillars which are used in the management of HFrEF. Unless there is an absolute contraindication to the use of any of these drugs, These 4 drugs definitely have to be in the prescription on the management of a heart failure patient. Okay. So, what are the 4 drugs? We have the ACE-ARB, the beta blockers, the SGLT2 inhibitors and the mineralocorticoid receptor antagonists. Followed by which we have the other group of drugs. Okay, let us look at each of the drugs one by one. So, first group of drugs. The first group of drugs is your beta blockers. Now, why are the beta blockers used in the management of heart failure? So, beta blockers basically block the sympathetic overactivity. Beta blockers block the sympathetic overactivity. So, we all know when we have read in the pathophysiology of heart failure that the first limb is basically sympathetic overactivation. So, whenever there is a failing heart, there is sympathetic overactivation so that the blood supply to the limbs is reduced and it's all directed towards the heart, and there is also compensatory tachycardia to maintain the output. But we know over the course of time that tachycardia itself can worsen the heart failure, and that is the reason why we use beta blockers. Also, beta blockers have shown a proven mortality benefit. Beta blockers have shown a proven mortality benefit. So, what are the beta blockers that have been studied and definitely been approved for the management of heart failure? You always remember MBC, which is metoprolol, bisoprolol and carvedilol. Okay, so beta blockers like propranolol, they are not cardioselective, they are not used in the management of heart failure. Beta blockers like nebivolol, they are not used in the management of heart failure. Okay, so metoprolol, bisoprolol and carvedilol are only the 3 beta blockers which have been approved in the management of heart failure. So metoprolol is started at a dose of 50 mg and a maximum dose of 200 mg, 200 milligram. Bisoprolol is started at a dose of 1.25 mg twice a day, and carvedilol is started at a dose of 3.125 mg BD. Okay. Now, what are the side effects of beta blockers? The side effects or contraindications is that beta blockers have to be avoided in cases of asthma or COPD because they can worsen the bronchospasm. They can worsen the bronchospasm. Okay. Generally, these cardioselective beta blockers do not have that much of side effects, but this is the only one contraindication in which you can use calcium channel blockers. But beta blockers are the first line drug and they have a proven mortality benefit. So, as much as possible, always prescribe a beta blocker. Fine. The next group of drugs is your ACE inhibitors and ARBs. So, what are these ACE inhibitors and ARBs? Now, you have already seen in the pathophysiology of heart failure that whenever there is a decreased perfusion pressure, the renin is stimulated from the kidneys and it causes angiotensinogen to be converted into angiotensin 1. Okay. This angiotensin 1 is converted into angiotensin 2 by this angiotensin converting enzyme which is produced from the lungs. Angiotensin 2 is having a downstream action. So, the downstream action of angiotensin 2 is that it causes vasoconstriction, salt and water retention, and it also causes stimulation of aldosterone. So, aldosterone in turn is again responsible for reabsorption of sodium and excretion of potassium. Okay. So, what is the basic principle of this ACE inhibitors and ARBs? So, ACE inhibitors are angiotensin converting enzyme inhibitors which act here. So, there is no further formation of angiotensin 2 and hence there is no vasoconstriction or salt retention. Now, ARBs are angiotensin receptor blockers which inhibit the angiotensin 2 directly. So, that is the basic mechanism of action of ACE and ARBs. So, what are the ARBs that are used? The ARBs that are used are losartan, LVC, losartan, valsartan and candesartan. So, these are the only 3 drugs which have been used in multiple studies and we have decided that these 3 drugs can be used in the management of heart failure. You would have all noticed that in patients with hypertension we give a very famous ARB which is telmisartan. However, telmisartan has not been approved as the ARB which can be used in heart failure. Though it is used, but the only 3 drugs which have been studied well enough are losartan, valsartan and candesartan. Okay, so that is about the ACE and ARBs. If you notice here, angiotensin converting enzyme is also responsible for converting the bradykinin into degraded products. So it is also responsible for converting bradykinin into degraded products. So if you give an ACE inhibitor, what are the ACE inhibitors? They include ramipril, and enalapril. So if you give an ACE inhibitor, the bradykinin will also be increased. If the bradykinin is also increased, there is an important side effect which is dry cough. Okay, so the important side effect of ACE inhibitors is dry cough. What are the other side effects? It can cause angioedema, especially in the black race. It is associated with an increased risk of AKI or the acute kidney injury and hyperkalemia. So if there is development of AKI or hyperkalemia, then you will have to stop or decrease the dose of your ACE inhibitors and ARBs. Okay. So another thing that you have to remember is that all of them have a class effect. The meaning of this class effect is that ACE inhibitors and ARBs act as a class. So any of the drugs can be interchanged amongst one another. Okay, fine. Now let us go to the next group of drugs, which is nothing but your angiotensin receptor blocker and neprilysin inhibitor, which is ARNI. Angiotensin receptor and neprilysin inhibitor. Okay, so how do these drugs act? We know that natriuretic peptides are degraded by an enzyme which is called as neprilysin. We know that from the pathophysiology of heart failure that natriuretic peptides help in what? They are responsible for natriuresis, which means sodium plus water excretion. Okay. So, don't you feel that if you increase the natriuretic peptide, then the heart failure will improve? So, if you want to increase this, you will have to inhibit the enzyme which is degrading it. So, you inhibit this neprilysin inhibitor. Okay. So, angiotensin receptor blockers are combined with this neprilysin inhibitors to form this ARNI. Okay. So, the prototype drug that we use is your sacubitril valsartan. Valsartan is your angiotensin receptor inhibitor and sacubitril is your neprilysin inhibitor. Okay. Now, if a patient is already on ACE inhibitor or ARB and you want to change it to an angiotensin neprilysin inhibitor, then you will have to give a 36-hour washout period. That is, you will have to stop the drug for 36 hours and then only start an ARNI. Okay. So, what are the side effects of ARNIs? Side effects include the same side effects similar to that of a ACE inhibitor. It includes hyperkalemia and AKI. So, if there is dose limiting, if there is a drug limiting hyperkalemia, if potassium increases by more than 6.5 in less than 1 week, then you will have to stop the drug. Okay. Also, they cause severe angioedema. Especially in the black race. Okay. So, these are the important points that you have to remember about the angiotensin receptor blocker and neprilysin inhibitor. The next group of drugs is your mineralocorticoid receptor blocker, which is your spironolactone. So, this spironolactone basically inhibits aldosterone. Okay. So, this is about your 4 pillars which are used in the management of heart failure. A newer non-steroidal mineralocorticoid receptor antagonist, because we know that aldosterone also has some amount of corticosteroid side effects and some unwanted side effects including gynecomastia. Okay. So, to avoid these side effects like gynecomastia and hyperkalemia, we have a newer non-steroidal MRA which is used, which is called as finerenone. Okay, so finerenone is a newer non-steroidal mRNA. Fine. Now we come to SGLT2 inhibitors, which is your last or the fourth pillar in the management of heart failure. So where do these SGLT2 inhibitors act? So this is your nephron. In the proximal convoluted tubule, you have a sodium glucose transporter. You have the sodium glucose transporter. So SGLT2 is the name of this transporter, and the drug which binds here goes and inhibits this transporter. So what happens is that along with glucose there is lot of sodium and water which also gets excreted. That is, there is osmotic diuresis. There is osmotic diuresis. So SGLT2 are the new drugs which are in vogue, and this has a mortality benefit as well. So the newest and the latest trials which were done in the years 2019 to 2022 have proven that SGLT2 inhibitors are the fourth pillar in the management of heart failure. Okay. So what are the SGLT2 inhibitors which we know of? We have the dapagliflozin and the empagliflozin. Okay. So these were initially used as what? If you remember, they were used as anti-diabetic drugs. They were used as anti-diabetic drugs. Also, these drugs have been found very useful in diabetic kidney disease as well. They decrease proteinuria in diabetic kidney disease as well. So, if you get a patient of heart failure with renal involvement and diabetes, then this is the best drug that you can use. In non-diabetic or a non-CKD patient as well, this has been found to have mortality benefits in heart failure. Okay, so that is about the SGLT2 inhibitors. What are the main dose limiting side effects is that presence of UTI. Okay, so in patients with a simple cystitis, you do not have to stop the SGLT2. That means that SGLT2 can be continued. Only in patients with life-threatening urinary tract infections like pyelonephritis, you will have to withdraw or stop the SGLT2 inhibitors. There is also an increased risk of fungal infections, fungal UTI with SGLT2 inhibitors. Why? Because along with sodium, there is a lot of glucose as well which is being excreted, right? So it causes glucoseuria. So because there is glucoseuria, there is an increased risk of infections. Another very important side effect is the presence of euglycemic decay. We all know that diabetic ketoacidosis is associated with high sugars. But because of the glucoseuria, these patients can develop DKA even with normal sugars. So this is your euglycemic DKA, which is a side effect of SGLT2 inhibitors. Fine. So that is about the 4 pillars in the management of heart failure. Now let us look at the other drugs. Now if we come back to this diagram, let us just see this diagram once more. If the heart rate remains to be more than 70 beats per minute despite the use of a beta blocker, then we use a drug which is called as ivabradine. So what is the mechanism of ivabradine? Ivabradine is basically a funny channel inhibitor. Funny channel inhibitor or the sodium funny channel inhibitor. So this ivabradine is used to reduce the heart rate even if the heart rate continues to be high despite the use of a beta blocker, and it does not affect the cardiac function, or it does not cause a fall in the BP. So ivabradine can be used safely. What is the side effect? The side effect is that it causes visual changes because the same sodium funny channels are present in the retina as well. So you find visual changes. Okay. The next group of drugs is your hydralazine and nitrate. This is used in those patients of heart failure who have a concomitant renal failure because this acts as a vasodilator. Okay. The next drug which has been used in studies is your vericiguat, which is a cyclic GMP stimulator, soluble cGMP stimulator. Then we have another drug which is levosimendan, which is also being used in trials. It is not available in India, and this is an ionotrope. So in cardiogenic shock, despite the use of dobutamine, if the patient is still in shock, you can use levosimendan. Another drug which is used, which has been proven in studies, is your omecamtiv mecarbil, which is a myosin stimulator. But this is not being used in treatment currently. Alright. So that is about the different other drugs which are used time and again in the management of heart failure. Now let us look at what is refractory heart failure. What is refractory heart failure? So despite the maximum goal-directed therapy, you've done everything that can be done for a patient of heart failure and is on the maximum tolerable doses of all the medications. In spite of that, he continues to be in NYHA4. Then you call it a refractory heart failure. Okay. In refractory heart failure, you have to look into 2-3 other causes. One is the presence of wide QRS complex more than 150 mm. In other words, you will understand this better if you go through the chapters on ECG. This basically means that there is a left bundle branch block. Like we had discussed before, if there is a left bundle branch block means what? There is a cardiac electrical dyssynchrony. Now there is a cardiac electrical dyssynchrony. If there is a electrical dyssynchrony means the LV and RV are not contracting together. If they are not contracting together, then this can worsen the failure. Now how do you treat this? Is using what we call as the cardiac resynchronization therapy. So this is called as the cardiac resynchronization therapy or the CRT device. So in this CRT device, what you do is you insert a pacemaker. Okay. So this is basically your bundle branch block. So what you do here is you insert a pacemaker such that there is equal electrical stimulation of both the ventricles and the contractility improves. Okay. So when do you do a cardiac resynchronization therapy in heart failure? In refractory heart failure with a wide QRS complex more than 150 mm. That is when you do a cardiac resynchronization therapy. Then if the QRS is normal, that means that there is no electrical dyssynchrony, there is no bundle branch block. In spite of that, the patient is in refractory heart failure. So there is a normal QRS. That means that the patient does not have any electrical dyssynchrony. In spite of which there is a heart failure, then you have to use left ventricular assist devices. Okay. So left ventricular assist devices basically means that you give some devices which improves the functioning of the heart, which includes something called as a intra-aortic balloon pump or an IABP. Okay, details of which is not required at this level. Then always look at the renal functions as well, because we know that there are forms of cardiorenal syndrome. So if the renal function worsens, the heart failure is also going to worsen. So if the renal function is very poor, then you initiate them on hemodialysis and see if the cardiac functions are improving. Alright. So that is about the management of refractory heart failure. Okay. Now let us move on to the management of acute decompensated heart failure. Acute decompensated heart failure is when the patient presents with heart failure. In a known case of chronic heart failure, they suddenly present with worsening dyspnea, orthopnea and so on. So you always rule out the precipitating factors we have already discussed. See if the patient was compliant to the drugs, has there been any new change in the prescription, or is there an MI or a pulmonary embolism or an infection or anything that has precipitated the failure. Now, there will be different phenotypes with which the patient presents. So let us look at the different phenotypes with which a patient of ADHF, acute decompensated heart failure, presents. The first type is the warm and wet type. The first type is the warm and wet type. In this warm and wet types, the BP is normal. Peripheries are warm, but there is pulmonary edema and systemic edema. So, the drug which you use to manage this type is you give them diuretics. You also look for the underlying cause. What has precipitated is in the acute management, you give them diuretics and you can also give some amount of vasodilators. Okay, you give them diuretics, give them vasodilators so that you decrease the afterload. Once you decrease the afterload, the cardiac function also improves. Okay, the next phenotype is the cold and wet type. What do you understand by cold and wet? It means that peripheries are cold, the blood pressure is reduced, the patient is in shock. Okay, and he has pulmonary edema. So, what are the drugs you want to use? You have to be very careful with a diuretic because the BP is already low. So, you give them inotropes. You give them inotropic support, increase the BP and then you diurese them so that you can bring down the condition. Okay, the next phenotype is your cold and dry. Cold and dry, we already know BP is also low and they are dry. So, for these patients, they are in absolute cardiogenic shock and you need to treat them with inotropes. Fine. So, that is about the different phenotypes of heart failure. So, how do you manage it step by step, right? So, once the patient comes to the emergency, if you diagnose him with heart failure, you stabilize him completely. You provide them with supplemental oxygen, make sure that the BP is okay and then you do an ECG. You do an ECG to rule out MI and in your ECG you can also rule out certain other precipitating causes like arrhythmias or if there is a pulmonary embolism. So, all of this you can find out with your ECG. You do an ABG. Why do you do an ABG? You can identify the renal functions. You can look for the lactate levels because lactate basically reflects the perfusion status. Lactate basically represents the perfusion status. If possible, you get a bedside 2D echo. With this 2D echo, you can find an MI if there is present of regional wall motion abnormalities. If there is a PTE or an arrhythmia, you can see all of that in an echo. Place the patient in which position? In a semi-recumbent position, because you place them flat, there is more breathlessness and more orthopnea. And if the BP is elevated, if this is a hypertensive heart failure, you start them on a vasodilator, which is nothing but glyceryl trinitrate at 5 micrograms per minute. Okay, you start them at a rate of 5 mics per minute. Fine. What are the drugs which you can use? Like we have already discussed, amongst the inotropes, the drug of choice is dobutamine. Among the diuretics, the drug of choice is furosemide. Okay. So, that is about the management of chronic heart failure and management of acute heart failure. Now, let us look at what happens in heart failure preserved ejection fraction. So, heart failure preserved ejection fraction is a comorbidity driven disease, right? So, all of these drugs have not found to have any benefit in the management of HFpEF. Only ARNI and SGLT2 inhibitors have been tried and there has been some benefit. So, always treat the underlying cause, in the management of heart failure with preserved ejection fraction. So, this brings us to the end of this session on heart failure and I hope you enjoyed it. Let us meet next time. Thank you.